Okay, welcome to part 2 of the session on electromyography. So moving through the applications of EMG analysis, let's have a look at prehab or prehabilitation, so the prevention of injury through exercise and training, so forth. So sticking with the theme of hamstring injuries, what we have here are 3 different hamstring stretches, and each one of them varies slightly based on the relative hip flexion of the limb that is being stretched to the contralateral limb. So if you look at the image on the right of the chap touching his toes, the hip flexion here would be more or less 0 because you're comparing the flexion of the limb that's being stretched relative to the other limb, and they're both in the same position, therefore there is no relative difference. If you look at the image in the middle, the chap here is stretching what I think is their left limb, yes it is, and the other limb is rested on the ground with his knee and foot in contact with the ground. So here we have a roughly 45-degree angle of hip flexion on the limb that is being stretched. And then in the case of the image on the left, the woman who has the band, you can see that there is over 90 degrees of hip flexion here. And this is the important variable. So EMG analysis helps us not only to understand muscle recruitment in terms of selecting the best exercise for training, but also the best exercise for stretching and therefore for prehabilitation, because a tight muscle is a muscle that is potentially one that's going to be at a greater risk of injury. So this is the output of a study, and I will upload the study onto Brightspace, that looked at the EMG activity and also compared this with ultrasound analysis of the 3 different hamstring muscles. So if you look at the top of each line graph, you will see ST, SM and BF, so semi-tendinosus, semi-membranosus and biceps femoris. Now the image of, let's just focus on the tendinosus for now. Along the x-axis we have the knee angle in terms of degrees of flexion, obviously. So as you move more to the right, you have a knee that is in greater extension. If you were to move back to the left, or at the origin, which is 110 degrees of knee flexion, that is a flexed knee. And conversely, the y-axis represents the relative degree of hip flexion. So from 25, 50, 75 degrees of hip flexion, and that is relative to the position of the other limb, the contralateral limb. And basically what this study is showing is that in each instance with each muscle, as the knee extension increases and the hip flexion increases, you see this increased activity within all 3 of the hamstring muscles. So the stretch reflex, which you're all familiar with to some degree on both an academic and a personal level. If you've ever stretched, you will feel a degree of discomfort, a degree of pain, and that is simply because the muscle spindles are being lengthened. They sense the length change in the muscle, and therefore they encourage the muscle that is being stretched to concentrically contract to try and shorten, to reduce that lengthening, and that's the discomfort that we feel when we're stretching. In fact, there are some that argue that stretching is nothing more than a case of overcoming the stretch reflex. We're all capable of lifting our, I don't know, legs up and bending our knee over our neck and so on, but we need to overcome the stretch reflex first. That's not necessarily, there are some that would disagree with that and say that you actually need to lengthen the tissue as well, but that's a story for another day. But what we're basically seeing here is muscle activity in terms of the stretch reflex. So not necessarily always looking for activity in terms of muscle recruitment for exercise training and resistance exercise, for example, but in this case increased activity suggests greater stretch because of a greater stretch reflex, and that is quantified here on this graph. So the best stretch for your hamstrings, regardless of what it is regardless of whichever muscle, is one where obviously the knee is extended, but that is complemented with hip flexion of the contralateral limb. And we can explain that rather simply here by going back to our two images of our chap touching his toes and the woman laying on the floor using a band to help her stretch. Now remember that the hamstring muscle group is biarticular. It spans across the knee and the hip just, and a muscle that is being stretched will pull on both of its attachments. So in the case of the woman laying down, because one limb, the contralateral limb, the limb that isn't being stretched, is maintained in a, let's just call it a neutral position, or a starting position say, whilst the other limb is being flexed, whilst the knee is extended. This helps keep the pelvis, rather large pelvis there, I've just realised I've animated on it, in a relatively fixed position, whereas the person on the right, and you have to look carefully for this because it's a very subtle animation, because he's touching his toes, the hamstring will try to shorten in whichever way it can. It will try and flex the knees, which I've tried to illustrate here with the free body diagram, the lines and dots showing a small degree of knee flexion, but also tilting the pelvis posteriorly. That's a very small movement, so let's do that again. See that? Just. And that's what creates this rounded back or spinal flexion that we see when we perform a toe touch movement. Because the hamstring is able to then shorten at its proximal attachment, you're taking some of the tension off the muscle, and therefore you're reducing the effectiveness of the stretch, essentially. So by far the superior stretch is one in which one hip is in extension whilst the other is in flexion. So you can do that with a band, or alternatively you can do it by laying down in a doorway with one heel of one foot placed up against the doorway and the other in contact with the ground. And again, just a nice example here of helping us understand muscle activity and its applications. The more traditional way in which we sometimes think of EMG analysis would be an exercise selection, and don't get me wrong, that's equally important. So here we're looking specifically at knee valgus. Now, knee valgus is a quite a complex phenomenon. In its simplest possible terms, if you look at the image here on the left, the skeletal figure, knee valgus simply involves the knee, the tibiofemoral joint, moving closer to the midline of the body, represented by that dashed line going down the middle of the image, whenever knee flexion is performed. So that could be jumping and landing, could be running, could be squatting, whatever. Whenever there's a reasonable amount of knee flexion, valgus is simply when the knee moves closer to the midline of the body. Conversely, varus, knee varus, is where the knee moves away from the midline of the body, moves further, so moving laterally, as opposed to valgus where it moves medially. Now, knee valgus is a complex phenomenon that requires adduction of the hip and also rotation, so the hip will have to rotate slightly internally in order for this to occur. The knee will abduct, so knee abduction is a bizarre phenomenon. It's not exactly what you would think. Hip adduction is where the femur moves closer to the midline of the body. Knee adduction is where the tibia and fibula move away from the midline of the body relative to the position of the femur, if that makes sense. It's there in the diagram if it doesn't. And this is complemented usually with ankle eversion, so rolling the ankle outwards, supination you could almost say. So it's a complex phenomenon, as I say, a combination of hip adduction, internal rotation, knee abduction and ankle eversion. If you add all those things together, then you have valgus. And knee valgus can be the precursor to a number of different injuries. This is associated with ACL, anterior cruciate ligament injuries. It's associated with MCL, medial collateral ligament injuries, because the MCL is positioned medially on the tibiofemoral joint, so on the midpoint of the knee, and that's going to be placed under greater tension in the scenario of valgus. And if those ligaments are damaged or sprained to the point where there is a significant tear, that will cause unnecessary movement to occur within that joint, which can damage connective tissue like the meniscus or the cartilage. So a severe ACL tear is often associated with damage to the connective tissue itself. If you look at images B and C, you have a nice example there of valgus and varus. Valgus is on the left, is image B, and varus is on the right, image C. And in the top right hand corner is just a way of representing it on a more sort of human global scale. You can see the three retroflective markers that have been positioned, one on the front of the hip, the ASIS, the patella, and the tibial tuberosity, which I believe you used in your project, possibly. So the knee towards the midline of the body. The image on the left here, the skeletal image, is a very extreme. That would be some very, very extreme valgus. It's usually more like the image on the top right. So which muscle or muscle group would we go about improving or strengthening in order to address such a complex biomechanical issue? Well, surprisingly enough, usually, not always I should point out, but usually we see valgus associated with a weakness in your hip abductors, the AB ductors, which I've tried to represent here on the left hand side with the skeleton with the two hip abductors attached. You have the superficial gluteus medius, and underneath, just poking out at the bottom there, you can hopefully just about see is the gluteus minimus. The gluteus maximus actually plays a role in hip abduction as well, and perhaps somewhat confusingly, adduction. The top fibres, if you like, if you were to view the glute medius posteriorly, the superior fibres of the muscle are involved in abduction, moving the leg away from the midline, and the lower fibres, the inferior fibres, are involved with adduction. It's a very complex phenomenon to try and describe, but we'll just focus on the medius, G medius for now, gluteus medius for now. So on the right, there are 1, 2, 3, 4, 5, in fact, different exercises. I've copied these images from a study that was done. I can't remember when off the top of my head. I will add it to Brightspace. But they are all of exercises that could be performed in order to improve the strength of the hip abductors, in order to try and reduce the instance of valgus. In the top right, you have perhaps the simplest exercise. It's simply laying on your side and abducting and adducting the leg in a straightened position. Just below that, you have the stepping to the side walk, one of Dr. Devereux's favourites, with a band placed just below the knee. I would actually probably just above the knee would be the best thing to do there, but never mind. And just stepping to the side, this engages the hip abductors. To the left of that image is a person with a dumbbell in one hand performing a contralateral lunge. The contralateral lunge involves performing the lunging motion, so standing upright, stepping forward with one limb, and then taking that to full flexion of the knee and the hip, whilst holding a dumbbell in the contralateral hand, the opposite hand. So here he's stepping forward with the left leg and holding the dumbbell in the right hand side. And you would perform this exercise one side at a time. And then at the bottom we have the plank, and on the bottom left hand side, plank maneuver, and to the right of that a sort of an advancement, if you like, of the plank where the hip is placed in abduction. So if you like, a little bit of a challenge, pause from here and perhaps consider which do you think, and these are all photos that I've, as I say, snipped from this study that look to see which exercise, this was just a few of them, there were more, but which exercise resulted in the greatest recruitment of the hip abductors. You can pause here if you so wish. So the answer is the contralateral lunge, believe it or not. The contralateral lunge resulted in the greatest hip abduction because one way to think of it would be, oh, hang on, there we are, I've got an animation for it, forgot about that. The dumbbell is essentially pulling this person's torso to the right hand side, so they're tilting over to the right, and what is preventing that lateral tilt of the torso is the hip abductors. Now, complementing that with the lunging motion just places a greater demand on the muscle fibre, so you can increase the load and increase the demand of the exercise more by lunging with any steadily increasing load. It's a more complex exercise, you could say, as opposed to the others that we've got shown here, which are more simplistic and ultimately resulted in less recruitment. So anyone with weak hip abductors, and there's a lot of us out there, I know I've got weak hip abductors, contralateral lunging is perhaps the way forward. And we would not know this without EMG. Everyone's, well, not everyone, but as I've said before, I'm sure there's a few of you that have been to the gym who like resistance exercise, who have at some point or another had someone come up to you and say, oh, you need to perform this exercise because it's the best at, improving the size and strength of this particular muscle. There's no way of knowing that without performing some sort of muscle activity analysis, like EMG. And this is how we're able to quantify that and actually prove whether an exercise enhances the recruitment of the muscle. If it does, that means greater hypertrophy, that means greater strength. They would all of these exercises benefit the hip abductor, but it's about which is the best, essentially, and in this case it's the contralateral lunge. Okay, let's take that a step further and look at the hamstrings. Now, this is a bizarre phenomenon where we've even found out that you can preferentially recruit the medial and lateral hamstrings. Now, this is of particular relevance if, as we said at the beginning, you play a particular sport. So footballers would want to engage want to improve the strength of the medial hamstrings. Most of us would want to improve the strength of the biceps femoris, because obviously they are the specific muscles that are most likely to get injured in the hamstrings. But is there a way to do it? Well, it turns out there are. So, well, there is. So, where are we? So, research and EMG analysis have shown that the lateral hamstrings are preferentially recruited, not isolated, I should say. It's not a case of the medial hamstrings are completely not engaged in these exercises, but the lateral hamstrings can be preferentially recruited with exercises that require or that involve hip flexion and extension, obviously, but they're engaged during the hip flexion extension movements. Whereas the medial hamstrings are involved in movements that require knee flexion and extension. So here we have 6 different hamstring exercises. In the top left you have the hip extension movement, so no prizes for guessing which one this is. The stiff leg deadlift should be fairly straightforward. The hamstring curl, straight leg elevated hip raise, so that's as is illustrated in the image, where either one or both limbs are positioned in an elevated position as you lie down, and then you perform a hip extension movement. The dreaded Nordic lower, which I'm not a fan of, but there it is. Nordic lower. The ankles are secured, so you start in a kneeled position, ankles are secured, and in a fixed position, perhaps get someone to lean on them or hold your ankles down, and you slowly and under control let your body fall forward. And the lunge, which we're all familiar with, just standard lunge, not the contralateral lunge, just standard lunge. So this would be normally where I would say take 5 minutes, but pause the video here and see if you can have a go at guessing which exercise preferentially recruits which hamstring group, medial or lateral. Which exercise recruits the medial, which exercise recruits the lateral. Okay, so 45-degree hip extension. Well, it's involved in recruiting the hip, or it involves hip flexion extension, therefore lateral hamstrings are going to be recruited. The prone leg curl, so just a standard hamstring curl, this involves knee flexion extension whilst the hip stays in a fixed position, therefore it's going to preferentially recruit the medial hamstrings. The dreaded Nordic lower is the motion is very much occurring around the tibiofemoral joint, therefore it is also an exercise of the medial hamstrings. The stiff-legged deadlift, if performed correctly, this person's performing it with hip flexion and a degree of knee flexion as well, but if the knees are kept relatively straight, it is obviously going to recruit the lateral hamstrings because it involves hip flexion. The elevated or straight-legged elevated hip raise, well, the clue is in the name, that is the hip raise. It's a hip-based movement, knee flexion doesn't change, therefore the lateral hamstrings are going to be preferentially recruited. Now what you'll notice is with the well, with each exercise, one joint is moving whilst the other stays in a fixed position, hopefully, if the exercise is performed correctly. So with the Nordic lower, the hip is in a fixed position where the knee flexes and extends. With the hamstring curl, the exact same thing. Hip is fixed, knee flexes and extends. With the excuse me, with the 45-degree hip extension, the hip is flexing and extending whilst the knee stays in a fixed position. Now, in the case of a lunge, you have simultaneous motion of the hip and knee. So this was a bit of a red herring. This is a very poor movement for the hamstrings, as is the squat, as is any exercise that requires simultaneous hip flexion and knee flexion. So just take away that neither sign that I put up there. If you can just about make out the chap in the bottom right, he's flexed his knee and flexed his hip, which means that the muscle is lengthened at the hip, so we're stretching the muscle at the hip, but it's been shortened at the knee. So because of this, the hamstring length stays relatively unchanged throughout this motion. Therefore, there is no preferential recruitment in either side of the hamstrings, lateral or medial. So the lunges are running joke in our lab. If anyone's ever exercising, we see them doing a lunge. It's often seen as a bit of a someone will shout lunge at them in utter despair. What on earth are you doing? I'm not saying it's not a good exercise, perfectly fine for the quadriceps and so on, and the gluteus maximus, but not the hamstrings. I believe the squat, in a study that compared muscle activity of the squat to the hamstring curl, standard prone leg curl, and looked at muscle activity of the hamstrings, recruitment of the hamstrings was 60-70% greater off the top of my head in the hamstring curl as opposed to the squat. The squat is not a hamstring exercise, and nor is the lunge. Now you may be asking yourself why. Hopefully you are. So here's the image we had on the previous slide. Now the muscle activity changes, but why? What is it mechanically that's going on here that causes the medial lateral hamstrings to be preferentially recruited based on either hip or knee flexion? Well, we simply need to look at the moment arm length of the two muscles. Now, I've borrowed this from Biodigital, this image from Biodigital, which perhaps doesn't do it full justice, but you can see on the on the right hand side here, the lateral hamstrings have a far shorter moment arm length. The red line represents the direction of pull of force of the muscle in either direction, and the lateral hamstrings are much closer to the axis of rotation of the tibia femoral joint, whereas there is a far greater distance between the axis of rotation of the acetabular-femoral joint, or the hip. Now, if you remember your torque equation, torque is force, so the force of the hamstring, multiplied by the distance that force is applied from the axis of rotation, in this case the joint, the hamstring, the hip or the knee. So there are two ways to increase torque or increase the rotational force that's produced by the muscle, and one of those is to increase force production, one of those is to, or the other is to increase the moment arm length. Now we can't physically change this, well actually no, that's a lie. Hypertrophy will change moment arm length, but we can't make a huge difference to it. But there is a far greater moment arm length between the muscle of the lateral hamstrings and the hip than there is the lateral hamstring in the knee. Whereas the medial hamstrings, the membranosus and tendinosus, have a slightly greater moment arm length at the knee as opposed to the hip. Therefore, they show preferential recruitment at the or in exercises that require knee flexion. And there's not a huge difference in moment arm length, but because the moment arm length is shorter in the lateral hamstrings, that compensates for the relative small distance in the moment arm length between the hip and the knee of the medial hamstrings. So it's not just a case of the moment arm length is longer in the medial hamstrings at the knee, which it is, but not by a huge amount, but also the lateral hamstring, the moment arm length is significantly shorter, therefore the medial hamstrings see a greater amount of recruitment. Okay, so that's the end of the session. Let's just summarize some of the points that we covered over the two videos. Because that's what your assessment's on, and some of those I've discussed quite obviously, others I've tried to be a bit more subtle about, but let's summarise them. So pros and cons, and this isn't an exhaustive list, there are others, and I would encourage some wider reading in your answers. It would be nice to see some additional information. Don't just go by what I've said here. Obviously, I'm hoping that you will use this as a way of signposting your learning. So pros and cons. As a pro, it's non-invasive. We don't have to stick a needle in you. We can put a sensor. There's a bit of dignity lost with being shaved and so on, but that's a small price to pay. It's better than having a needle inserted in you. So it's a non-invasive technique. It's very easy to apply. We can record for a significant amount of time, and as long as necessary, and we are able to reproduce the testing very easily. Doesn't take long. You just literally have to apply the sensor again, perform the same movement, and we can reproduce the methodology that we've used. So it's easily reproducible. You get a global assessment of muscle activity in most instances. However, as we said, with very long muscles, perhaps not. You may need to apply two sensors, but then this starts to cause an issue with the fact that you need to position your sensor near the muscle belly, and if you start to position it nearer the tendon, that's a region where you see fewer nerves. It's less well innervated, therefore there's a bit of a trade-off there. So there's pros and cons to both pros and cons to both. And it combines very well with other techniques. As we said at the beginning, it completes our understanding of human movement. You can easily put on a set of EMGs whilst someone's, well, for example, one of your projects that you've done, it would be very easy to attach some EMGs. We simply didn't because you've got to learn about it first. So global recording muscle activity, question mark I'd have next to that. It's not invasive, unlimited recording time, reproducible, and it combines very well with other techniques. But it's by no means the only technique out there that you can use, so that's something to consider. We discussed very briefly needle electromyography and even more briefly mechanomyography. Are they better or worse? That would be a good area to read up on. Just a few cons. superficial muscles are the only muscles that we can assess, unfortunately. Again, you can use needle electromyography to plunge a bit deeper, but unfortunately we're stuck with the superficial muscles. There is the possibility of the crosstalk phenomenon, where we start picking up on activity of the non-target muscle, or even the heart in some cases. There is the classic easy to use and easy to abuse issue. It is a straightforward technique, but at the same time it does require some skill and learning to master it. As we discussed, I think in your practical session, it is a technique that requires a certain degree of, how can I say this, experience with regards to sensor placement. The CENIUM guidelines are useful, but they are very heavily criticised by some who say, well, what is this based on? There is no solid research, the last time I checked, to say that the CENIUM guidelines for sensor placement are optimal. They are simply logical, because they are for each muscle. The CENIUM guidelines give you a way of finding where the muscle belly is, but is that necessarily optimal for data collection? You would think so, but at the end of the day, those guidelines are essentially made up of a series of expert opinions, and just because someone's an expert doesn't mean their opinion's always correct. And another point that we discussed during your practical session, anthropometric variables can be an issue if someone has a large amount of adipose tissue. Any structural issues, someone that's taller is going to have longer muscles versus someone that's perhaps significantly shorter is going to have much shorter muscle bellies. So you have to factor in height into your analysis, and you would possibly want to exclude people that were too short or too tall. I think that's everything. Anyway, I hope that's useful, and as I say, as always, any questions, drop me an email, and hopefully everything's okay with these videos. Let me know if they are.